So I think we'll get started, especially given the internet audience. It's my real honor to introduce and bring up Peter Rhee. I think words like iconic and luminary are often overutilized, but with Dr. Rhee, they really do fit the bill. As you can imagine, his CV is as ridiculously long as Dr. Maddox and Dr. Feliciano's, but some of the interesting highlights of that, really all of his work, the fact that he was a U.S. Navy captain for 24 years, 290 peer-reviewed publications, 600 presentations, dozens of books. The Tactical Combat Casualty Care Committee, which is a really important committee, as we all know, and a lot of really, really vital work. Big leaps forward have come out of that committee. Most recently, he's taken on the job of the Chief of Acute Care Surgery, as well as the Medical Director at the Marcus Trauma Center, and in particular, Grady Memorial Hospital as a whole. And I think most of the nation is very happy that Peter has taken that job and will reinvigorate Grady, which is home to a lot of us. So thank you very much, Peter.
Thank you, Dr. Ball, for that warm welcome. So what I'm going to talk about today is preparing your community for disaster, and what that really means, and kind of talk about what our job is going to be. Now, I know that the internet audience is the majority, and a lot of those are in Latin America and also in Canada as well. So I just thought I'd take a little opportunity to discuss a city that I'm now moved into, is Atlanta, Georgia. This is the trauma center there, and it's predominantly a trauma center, and they offer full services. It's about 1,000 beds. It's right downtown Atlanta, Georgia. And we call it the Marcus Trauma Center because Bernie Marcus, who's the co-founder of Home Depot, has given us a lot of money and has been philanthropic for the whole hospital, and we could not function without his generosity. But the trauma center is like most urban trauma centers, public hospitals in the United States. Atlanta, Georgia, for those who are not familiar with the United States as much, is a city which now states that it's got about 5.7 million people in the metropolitan area. Georgia is a state in the south, right on top of Florida. Lots of southern hospitality, and these are some of the major cities around Georgia itself. Now, one of the things that Atlanta, which is proud of many things, is that actually it is the busiest airport in the entire world. And as a result of that, the commerce that occurs in Atlanta, Georgia is very heavy, and we're very proud of that. There are other aspects of Atlanta which make the city a beautiful place to be, and I really would invite everybody around the world to come and enjoy it when you get a chance and opportunity. That's within the city itself, like most metropolitan cities in the United States. Other than the congregation downtown, there's a lot of rural aspects of it, but there's plenty to do within the city itself. In the downtown area, the zoos and the museums and the SeaWorld parks are also plenty there as well. And then if you get a chance to go out to the periphery, there's an example of many of the rural lifestyles that go on in that metropolitan city as well. It obviously, with that large number of people that live in the city, has all of the major attractions, including all of the sports as well. So with that, I thought it'd be a little bit different than a lot of the medical things that we're going to discuss, but preparing the community for disaster. And what I wanted to do was not be too exhaustive or extensive to talk about this topic, but it is a concept that we wanted to push through and explain to the world what the Hartford Consensus is. In the trauma community and the academic portions, I think everybody understands what the Hartford Consensus is. And in the American College of Surgeons, we're starting to learn a little bit more about what that means. But this is a way for us to spread the word about the Hartford Consensus to the other countries as well. And what is the Hartford Consensus? So this is what I'm going to talk about, and I'm going to explain how big of an effort it is with the supporters that are involved, introduce the audience to the concept of what we're trying to do, talk about who, when, why, and what it really means to you in the audience. Without showing you a lot of videos of natural disasters and things like that, I think we all are aware that weather patterns are changing, and we are actually feeling a lot of this, especially since 75% of the world's population live within the coastline, what we call in the military the littoral places. And they're suspect there's a lot of damage that can go on. But in the United States, as it is, and also other countries, violence, interpersonal violence, but also these crazy things and occurrences are happening everywhere in the world, and whether it's done by guns or with buses or anything else like that. But when we have these kinds of events, are we prepared as a community to respond to it as best as we can? In the United States, I think there's no issues about guns, meaning being ample, and it is a political decision that they've made at this current time period that we have the capability of purchasing a lot of these guns. And we're at a point where now the number of guns in this country outnumber the number of people. Close to over 350 million people, and the number of guns are almost enough for every single person to be armed. Some facts, these are opinions and facts, but I think that you would agree that they are factual. Where there are no guns, there will be no shootings. Where there are guns, people will get shot. And where people get shot, people will need trauma surgeons. It's just a known thing that when I was in the military and you were doing things with your battalion, when they didn't have guns, no one got shot. And when you gave them guns and bullets, you knew someone was going to get shot. So the mass shootings that we're doing in our country also is escalating, as we all know. This isn't just in the United States. Even in Canada, the shootings are occurring on a regular basis nowadays. And we wanted to be able to take lessons from the military, which has some shootings involved, and see if we can translate that to the civilian world. And that was there was a need for that, and that's what we wanted to do. Now, I was in the Navy for 24 years, worked with the Marine Corps the entire time period. My brother was a Marine Corps colonel in the infantry, and as a result of that, that influenced my decisions to become a trauma surgeon. But one of the things that I assumed was that the military was very well organized and had a methodology just like they did on how to take off your clothes and put them on and how to use every single instrument. They had guidelines and instructions. But we found out that from the medical perspective, there was no consensus, there was no governing body, and there was no agreement on how people should be taken care of in the pre-hospital field or in the field itself. So we came up with the Tactical Combat Casualty Care Committee, and it really made a big difference because what it did was it segregated the perpetual and permutations of what could happen. So when you would say, this is how I would take care of this type of injury in this scenario, the arguments were just exhaustive. Well, in my scenario, you don't have this or you have that, and you might be 2 hours for evacuation and so on. So it helped when we put a different kind of categorization, which was care under fire, what to do when you're actually under harm's way. There's bullets and bombs actually being flown overhead. And then there's tactical care, which is what you do after the firefight is over, and that is a safer environment. And then finally, evacuation care, how to give military care during transport. So that was when we started to come across a lot of these guidelines and looking at all of the things that we can and cannot do in the field. And one of the major issues, as we all know in trauma, is that bleeding is an issue that we should address, and if possible, no one should die from. This is a journal article in the Journal of Trauma this month in June. Actually, I wrote this. It's a review of ballistics and bullets, which I think a lot of the civilian trauma doctors and people who work in the trauma field have a lack of knowledge. It seems like the people outside of medicine have a tremendous amount of knowledge on this, but sometimes we don't, and that was the main impetus as to why we wrote this article. But the table that I show here is something I constructed of all the mass casualties and mass shootings that we've had in the United States just in the last 15 years. So when we have these events and we have a shooter that's going to injure a lot of people at once, what we are trying to do is get the world to start acting on this right away. And I think that while this was intuitive in many ways, a few decades ago, maybe 3 or 4 decades ago, in the last couple of decades, especially with the HIV scare and bloodborne pathogens worry, we have really sometimes wondered whether we should be putting our hands into this field. And this is why we wanted to act and start teaching people how to stop bleeding right away. Now, the concepts behind this are exceptionally easy. It's not really that big a deal, but the question is, how are we going to promote this and carry the act out? Dr. Len Jacobs is a surgeon in Hartford, Connecticut, and that's why it's called the Hartford Consensus, and he has done a masterful job of collating people and rounding up a variety of societies and associations, so we're in agreement. And with the political tact that he does have, we were able to get together and come to consensus on some of the things, such as a simple idea of stopping bleeding in the field. Numerous meetings, taking long periods of time to make simple decisions, but that's what has to happen. You have to have a master negotiator of the bureaucracy in order to get these things accomplished. And then recently we finally came to meet again on the 3rd event to talk about how to actually implement the idea of stopping bleeding as soon as you can. And why is this important and why is it a big deal at all? Well, 40% of the active shooters in the last decade or so are done in stores and industrial sites. Most are all individual shooters, and these are lessons that we have learned overall that's going to help us. But because of this type of scenario, what we want to do is we want to start empowering the public to act quickly rather than just standing by and watching someone that could possibly die. So we have the acronym THREAT. Dr. Duchesne went over this earlier today about threat suppression. That's something that's a little bit more law enforcement oriented as to how you as a victim or a person in the audience is going to work in that area. But he talks about whenever you can to do it, and then to worry about and do something about hemorrhage control. And then obviously when you have the opportunity to get more medical care when you can. So when you have blood, how are we going to empower the audience to do this? Others have talked about that threat capability in many ways, especially in law enforcement, and they call it run, hide, fight. But again, we wanted to just really emphasize hemorrhage. So when we push the idea of hemorrhage control, the critics of this, or people who are wanting to debate this issue, what could anybody possibly argue about our desire to stop bleeding? And they've come up with other things which may distract us, but really we need to focus on the fact that we can't take care of the world's problems, but things such as airway for a bystander or somebody who's the first responder, whether they'll be able to do something about the airway is a difficult scenario. And in shootings, airway usually is not that big of an issue. If a person has been shot and they need an airway, the capacity and the capability of the first responder to do something may not be evident or doable anyway, so it may not be a preventable thing. And that's why, again, we're going to focus on hemorrhage. Helping the public to stop the bleeding, will it work, and is it going to be cost effective? And the fact that we want to get away from bystander. So we talked about bystander CPR. I think if you look at the ability of that organizations, the cardiac doctors in the world, to promote and teach basic life support and first aid, and then finally CPR. And I remember when I went to college in Atlanta, Georgia, one of the very first things I did as a freshman was a mass in an auditorium, and we were all CPR certified. If we can teach people to do airway and breathing and circulation and pump on the chest, is it something that we can do to help people stop the bleeding that occurs after shootings? So again, we wanted to make a big deal about the bystander, and we all know that that's going to be anybody and everybody, and in normal disasters, people always respond appropriately, but we just, from a political correctness point of view, wanted to get away from the word bystander because it has a connotation that you're just standing around and not helping. The 3 levels of responders, again, to show the difference between the professional first responders, which are the EMTs and the police officers and the firemen, but the immediate responders, those are anybody that's by, and we want to teach the world and teach the civilians and everybody around that, you are a responder and should respond. So one of the things as to why we're talking about this obvious scenario of stopping bleeding is because the reality is that it takes a fair amount of time at the scene. When you have a car accident and the ambulance gets there, they will start extricating, assessing, and then moving that patient to the higher level of care. But when you're in inner city and you just have a simple shooting in an apartment and the police and firemen and also the ambulance come, if the ambulance comes first, their job is to sit and wait and not go into the building. And a lot of the medical personnel are not aware of that, and they wonder why it took so long to get that patient there. But the scene has to be secure before you can put other people at risk. And in these mass casualties and disasters, the same thing's going to occur, and it's going to actually really elongate the time period of when you're injured to get to the actual hospital. The scene has to be secured first. You have to make sure that no one else is going to get hurt, and then eventually go towards extricating the patient to the hospital. Now, because of that type of scenario, which is becoming a reality, we wanted to put kits out there for the public to use. First aid kits, basically, in many ways, except is geared towards hemorrhage control. If we can put automatic defibrillators all over the country, is it possible for us to put hemorrhage control kits next to them or in places where they may be needed? And what would be the reason why we couldn't do that? So the most important gear, I think, in this kit that we've constructed and thought about, we didn't want to be specific about what device and what proprietary devices to use, but we needed to be very, very generic, especially when you're working with so many manufacturers and also organizations. But the first thing that makes sense is the gloves. We want to give them a sense of safety for themselves by having within the kit gloves, and I think that that's going to be probably the first tool that the first responder is going to have, or the immediate responder is going to have, to be able to safely act. Gauze, pressure dressings, which are just sterile, again, obvious, but when you're in a school and you get shot and you don't have that, you're going to really wish for that, so that's what we wanted to really push on it.
Thanks a lot, Dr. Rhee, for this kind presentation. Is there any question from the audience?